Hi. How's everyone doing? Sounds like you're pretty good. All right. How's your course going so far? I'm not being superficial here. I'm actually asking. So, everything going good? All right. Well, now it's not. Just kidding. I'm going to be, I have you now for the next, what do I have, 6 lectures today? 5? It'll probably feel like 6. And then tomorrow I have you for more. So I basically take pride in the fact that this group of lectures I'm giving is actually very target rich. I like to say that also obviously to keep your attention the whole time, because some of the subject matter seems like it could be a bit dry, but I think overall each of the topics we're covering are going to be very critical for both written and oral. So how many people are taking oral? Okay, so most of you aren't, and that's okay. I talk on both sides of that fence. Okay, so most of my discussion and presentation, you don't need to hear the whole afternoon version of thyroid cancer, because thyroid deserves like a whole day topic, right? So I got to give you something in 1 hour. And so mostly what I cover is it really is very practical towards what you need to know. Now, there's those pieces of the puzzle that you didn't know that are straight up facts. Those are easy. They're like A, B, C, D, E, multiple choice question type of stuff. You just should know it. And then you have the critical thinking piece. That's very hard to pull out in a sort of lecture format, but it will happen. And so you'll find that you'll work with me on that issue. And one of the goals I'll have is I really try to help imprint. You know, a lot of lecturing is done where you just hear it and you're just kind of going over. But I actually do some things, I work up here, okay, to get you guys to sort of imprint and lock it in your head so you don't have to keep looking back at this stuff. And so hopefully it'll play out in that direction. And so we picked one of the bigger topics to start off. And thyroid, I know every program should be exposed to thyroid disease, but not every program has necessarily a high volume or necessarily exposed to all the different factors that are going into the controversy of the management of this subject. So what I'll try to do is try to give you that really important baseline from which you can work. And yes, there's a lot of different pathways on each of the decision processes, but I think we can find some tight, non-controversial line with all of this. The first is the facts, right? So the most common is what? Papillary thyroid cancer. And one of the things we know about that is that it has excellent survival. However you want to argue, you want to approach the problem from a surgical point of view, how much work you want to do with regard to the presentation of thyroid cancer, most of the patients will do well, okay? The thing to consider in all of our patients is the pattern of spread. Usually I don't show you the answer in a lot of my slides, so here's the answer. Which one is the most common with regard to metastasis, lymph node or hematogenous with regard to papillary? All right, so it's going to be lymph node. Does a presence of lymph node metastasis change survival? No. So metastatic cervical metastasis with the presentation is not necessarily a poor prognostic indicator. And the other factor that's present is multifocal disease, right? That's what drives us to consider that the majority of our papillary thyroid cancers will undergo what? A total thyroidectomy. Majority of them. Almost all of them, right? At least consider it. I'm not trying to be concrete operational here. I'm just trying to give you a baseline because there's a lot of exceptions to each of the rules I give you. This one included, because we're not necessarily, the pendulum is swinging right now with thyroid cancer to be less aggressive, okay? But right now, we know that the reason to do total is what? Multifocal disease. What's the other thing to consider? Well, we know that the histologic features have some very important facts. So start telling me what are some examples of classic features histologically in papillary thyroid cancer. Okay, some homobodies, what else?
Nuclear groove.
Mm-hmm. Nuclear groove, what else? Okay. What's the classic one? Someone must have said it. I'm sorry if I didn't hear it in all of it. So what's the other name for orphan Annie eyes? Yeah, clearing, central nuclear clearing. So what do you see on here? You see both of those features, the two main ones. You see, what's this? Bobby, right. And what are these cells? Let's take a closer look. So mobiles and central nuclear clearing. What's the other name I heard? Orphan Annie? Does anyone know who Orphan Annie is? Who's Orphan Annie? Well, what the heck does Orphan Annie's name, why does it get tied to something that looks like this? Huh? Why does it get tied to something that looks like this? Because of central nuclear clearing, and it's the cartoon. Have you ever seen this cartoon? It's not, something we see anymore, but what do we see aside from this creepy look? You see pupils are missing, right? Pupils are missing. Just for the record, anybody who's seen Orphan Annie in Broadway, all the performers on the stage had pupils, okay? Okay, so we know that Orphan Annie eyes are a feature. Now you know the tie-in to it. And again, a lot of these things are, again, to imprint. My goal is that you don't have to look back at this again. The picture did it for you, right? Okay. The other features that we should mention in terms of the histologic features include cystic degeneration. One of the things we recognize is that sometimes you see a large cyst, you drain it. What does the fluid look like in that situation? It's motor oil. It looks like motor oil. It's a very important characteristic you see within a cyst of a papillary thyroid cancer within the gland. You actually can see that also in cystic metastasis. So when you draw the fluid out of the cyst and you see that motor oil appearance on the cyst, cystic metastasis in a lymph node in the neck, you see the motor oil. That supports also your consideration for papillary thyroid cancer. And then finally, you see these papillary fronds, right? That's part of the foundation for the name to describe papillary thyroid cancer. And then as far as histologic, the correlation to behavior, you know that there's variations. You have follicular variant. When you see a papillary thyroid cancer with a follicular variant, what feature in that thyroid dominates? Is it the papillary or the follicular, just for the record? It's usually the follicular. So what you usually see is a follicular neoplasm as you're cutting through, and then somewhere along those cuts you find a couple of features that are consistent with papillary thyroid cancer, and that then becomes papillary thyroid cancer with a follicular variant. What's more important with papillary thyroid cancer with follicular variant is that you already know the pattern of spread with pure papillary. What happens when you have a follicular variant? What happens to the pattern of spread? You have increased what? Hematogenic metastasis. All right? All right. And we'll talk about why that happens. What is the reason for that, by the way? Increased incidence of angio invasion, which is a feature of the follicular adenocarcinoma. But we don't see that in true papillary, right? That's only when you have the follicular variant. Torsal variant is something that can be used by our pathologists to describe more aggressive features of papillary. Many of those actually just fall into the overall description as being more poorly differentiated, okay? Second most common is follicular adenocarcinoma, excellent survivals, as is with papillary. Patterns of spread shifts, right? It flips. So this is not typically lymph node. This is more commonly what? Hematogenic. And what do we say is the reason for when you have a follicular pattern? Yes, angio invasion. And in the end, that's how you establish your diagnosis. So the question really, one of the foundations of not only your knowledge, but now bringing your knowledge to the critical thinking, is this foundational understanding histologically of follicular adenocarcinoma of the thyroid, where it is very important to be able to distinguish between follicular adenoma versus follicular adenocarcinoma, but it's not there for you at the initial phase of your workup. If you do a needle biopsy and you see a follicular neoplasm, you cannot use that needle biopsy to establish that you have cancer, correct? Yes. Right? Because of a couple of things that we need to be familiar with. There is the follicular neoplasm. Nowhere in this picture can you say that this is truly a follicular adenocarcinoma. All you can say is it's either a follicular adenoma or follicular adenocarcinoma. And what are we going to look for? We're going to look for either vessel or capsular invasion. I think just to set the record straight, we know that capsular invasion has a bit of a controversy. Is it just through partial capsule? Is it through and through capsule? Most papers agree that whether you have capsule invasion or not, it's the angio invasion that's the most important thing. Okay? So when we're looking for the angio invasion, we really need to have a pathologist who's going to really thinly deli slice that specimen and look very comprehensively at every single slice to look for this. And do you see it? You all see it? That's an endothelium of a vessel. My coffee is showing right now. And then there's the endothelium right there. And then, whoa, what's that? That's the adenoma. And there, what's it doing there? Angio invasion, okay? All right, so that's straightforward. You see it. That's what they're looking for, and that's how you establish, and that's when you move from an adenoma to adenocarcinoma. So it's identified where on permanent section it is not seen on FNA or frozen section. If you're getting frozen sections for your thyroid nodule that you're operating on with a suspicion for follicular neoplasm, keep in mind you're not going to find the angio invasion. Why are you getting a frozen section? I mean, there are a couple of arguments for doing it, but it's not to find the angio invasions. You're not going to find it on frozen. It's if you may find a papillary, because that's actually the diagnosis, and then in which case you use that information to move forward. But in the end, you cannot use a frozen section. You have to use a permanent section to decide if that's true angio invasion adenocarcinoma. Less common version of follicular adenocarcinoma is what? Hürthle cell variant. It's more aggressive. It's based on the presence of Hürthle cells. Not just a couple of Hürthle cells, but a predominance of Hürthle cells. Whatever that percent you believe, it's in the 70s, I think 70, 75, I can't remember the exact number.